Welcome to the Bariatric Nutrition Coach podcast, where we empower you with weight loss surgery, nutrition knowledge, mindset advice, and inspiration so you succeed in your weight and health journey. I'm your host, Jane Stoltz, and I am a bariatric dietitian who has helped over 1,300 people on their weight loss surgery journeys. I'm also a solo mum, lover of long walks while listening to podcasts, partial to a glass of wine, and the ocean is my happy place. Join me as I dive deep into bariatric nutrition and lifestyle topics and deliver them to you in bite-sized, palatable episodes every Monday. Now let's go. So welcome to this week's episode of the Bariatric Nutrition Coach, and I have a very special guest with me today, who is Dr. Andrew Kiyingi. And I'm going to introduce Dr. Kiyingi first, and then I'm going to ask him to share a little bit more about himself. Dr. Kiyingi is a specialist. He's board certified. He's a bariatric and general surgeon with over 20 years clinical experience, though he doesn't quite look old enough for that amount of experience. He's a surgical trainer for the Royal Australasian College of Surgeons, and he has founded the Perth Bariatric Surgery and the BMI Specialist Clinics in Perth, Western Australia. So welcome, Dr. Kiyingi. Welcome to the podcast.
Thank you. Well, thank you, Jane, for the lovely introduction and obviously this opportunity to talk a bit more about bariatric surgery and obesity and all the things that are interesting. A little bit about me, I guess, regarding my background. Yes, over 20 years of experience. I get the comment a lot, yes, about I look a little young, but somehow I managed to do that without too much sleep, which is I find amusing. But
positive.
Not only am I a bariatric surgeon, some people may also not know that I'm very much a general surgeon as well. So I do a lot of other things in addition to weight loss surgery. So things like gallbladder surgery, hernia surgery, endoscopy is also part of what we do. In terms of my journey to this point, I really took up an interest in weight loss surgery through my training, and that was quite a while ago, but that led me to do specialist training, not only in Australia, but also overseas in the UK. And coming back here, I established the Perth Bariatric Surgery Service as well as BMI Specialist Clinic. And one of the unique things that I felt was that understanding obesity as a fairly multi-pronged or complex condition requires a multi-pronged approach. And that's very much the heart of what we do at BMI Specialist Clinic. We try to provide truly multidisciplinary service where not only do we see the patients from the beginning to the end, but we provide all the steps along the way. So someone doesn't necessarily even need a referral to see us. We have an in-house GP that provides that service, and we take them each step of the way to see myself, my dietitian, our psychology service, but also after the journey when they've succeeded and lost weight, we have an in-house plastic surgeon as well to look at things about excess skin and appearance and cosmetic skin treatments as well. So it's really the whole comprehensive journey that we provide here in Perth at the BMI Specialist Clinics, and I'm very proud of that.
Beautiful, beautiful. Now, it is lovely to have that holistic care, and people, I can imagine, really appreciate having one place and getting that one relationship to go through that whole journey with them. So thank you so much for sharing. Before we jumped on and started recording, I shared with you part of the reason why I invited you to come on my podcast and share your experience is because I've seen online comments and thoughts around the GLP-1s. That's what we're talking about today. We're talking about the role of GLP-1s, what can be the role of GLP-1 medications in the bariatric journey. And I've seen comments online where people I get the impression that they're thinking, I have GLP-1s or I have bariatric surgery. And there is a lot of information out there on the GLP-1 medications, and I think it's going to continue because there's a lot of research in the area and they're proving to be very helpful. So I wanted to have a podcast episode exclusively on where they can play a role. And I think of things like tools in the toolkit. So we're going to talk all about that. How does that sound?
Fantastic.
Beautiful. And I was sharing with you, and I suppose to give a little bit of format to kind of the stages or the areas we're going to talk about, and then we can start off, is when I'm looking or when I kind of talk about the bariatric journey and go to kind of that, if you look at, say, that 10,000 feet and really look at a big picture, we have that pre-surgery phase, we have the weight loss phase, and then people move into a maintenance. So I thought that could be a nice structure for us to kind of help us meander through this information. So if we use that, let's start at the pre-surgery. When you're seeing a patient pre-surgery, talk to me about, yeah.
Fantastic. What I thought would be good, just to set the scene for those who are new and aren't familiar actually with the term GLP-1, because it's thrown around quite a bit, just what these medications really are. And a lot of people have heard of them in a different name. And names like Ozempic and Wegovy and Mounjaro, these are drugs that have exploded onto the scene, and these are the GLP-1 medications. Now, GLP-1 actually stands for glucagon-like peptide-1 a receptor agonist. It's actually GLP-1RA, and that's a bit of a mouthful, but really that's the underlying name for these drugs. And these drugs are based on a naturally occurring hormone in the body called GLP-1, and we all have it. And that's made in the small intestine, and it's made in response to food or to meals. And we've actually discovered this hormone is very powerful in very many ways in benefiting people who are not only losing weight, but also have type 2 diabetes. So it works by a couple of mechanisms. And the main ones being, number one, it actually enhances our response to insulin, or enhances the way insulin works when we have a meal. It makes insulin effectively more effective. And that's really the reason why these medications were initially developed for type 2 diabetes treatments. These medications are also very good at delaying the emptying of the stomach, or gastric emptying. And that has an effect of allowing people to feel full on the same meal that they've had, because in effect the meals sit in the stomach for a bit longer, and so that also leads to a weight loss effect. And the other way in which they work in relation to weight loss is actually act centrally on the brain, in one of the areas in the brain called the hypothalamus, and that's an area that regulates our hunger and satiety and the way we feel hunger, and it actually enhances the effect of feeling not hungry, we'll say, or satisfied. And over time, when they initially gave these medications to diabetics, they found that people was losing weight, and then it extended to weight loss in itself. The other interesting thing about GLP-1 as a hormone is that when we do bariatric surgery, in particular gastric bypass procedures, there's a spike or increase naturally in this GLP-1 medication. So you actually get a natural boost in these GLP-1 medications from weight loss surgery itself. So the drugs that have been developed mimic the effect of this hormone. And that's where we've seen that they've been very, very effective now as an option for patients for weight loss, but also they do play a role in the journey for many patients that they may consider when they're having weight loss surgeries. So medications, when we talk about the word GLP-1, it's the underlying hormone. The medications, when we talk about the specific drug names, we talk about words like semaglutide or liraglutide or tirzepatide, but then they're advertised as drugs like Ozempic and Mounjaro and Wegovy.
The brand names, got it. Yeah.
The brand names. And those are the names that you'll often find online with obviously a lot of conversation. Now, if we just kind of lean into the journey for someone who's going to have surgery, we look at prior to surgery. Well, prior to surgery, when I see a lot of patients, often the conversation is about, well, by the time they come to see me, and look, we also prescribe GLP-1 medications on their own for weight loss. So we don't just offer weight loss surgery, but weight loss non-surgical options, is that many patients have tried a lot of things to lose weight, and they've had a lot of challenges along the way. And sometimes medications have already been part of their journey, where they've tried a certain medication like a GLP-1, and they may have had some success for a period of time, and the effect wears off, or they find that it's not for them with the side effects, or maybe the cost is prohibitive, or potentially there might be supply issues. So there's lots of different reasons. But our focus when we see a patient prior to surgery is to, firstly, we assess their suitability for weight loss surgery in general. And gastric sleeve and gastric bypass are really the two key types of operations that are now as the most effective treatments for weight loss. And there's lots of different steps or criteria to qualify for surgery. One being obviously the BMI, where that sits, and typically someone with a BMI above 30, we consider them, and there's maybe some other criteria there, but above 35, it's more likely that we then start to talk about surgery itself. And then we just assess them through our program. But when we talk about medications in that, I guess, scenario, we're really focusing on losing weight before surgery. And that's really the part of the conversation. If we're going to introduce someone to medication prior to surgery, it's in the context of two things. Number one, are we going to try and lose some weight before surgery, and why would we do that? And number two, it might be in the context of diabetes treatment as well. So someone might ask, why would you look at losing weight with another means when I've come to lose weight with surgery? Now, in different reasons behind that. But losing weight actually as a whole before surgery actually benefits your surgical journey. And that's a huge thing. Any weight someone loses before the operation actually pays itself forward in many ways. Firstly, from the point of view of the safety of the operation, if someone comes in for surgery at a slightly lower weight, and we might say they lose about 5% of their total body weight, it means that the surgery technically is going to be probably a little bit easier and a little bit safer. It might be a little bit shorter in terms of the anaesthetic time. The anaesthetic will probably be a little bit safer. And also the post-surgery recovery in that early period when you are lighter on your feet, a little bit more active, things like that, and just the way in which you are able to cope. It's like training for a marathon in some ways. It's a little bit safer. So there are reasons, whether you're using GLP-1s or other non-medications, to see losing weight before surgery is a beneficial process. But also, in the context of saying, if someone's looking to have surgery for weight loss, it actually helps some people to start that journey to lose weight, to not only get a bit of motivation and momentum, but later on we find that patients who lose weight before surgery actually do a bit better afterwards. And there are good studies to show that. And that, I guess, in some ways shows that the body feels the momentum of losing weight prior to surgery and carries that through with the operation, and they often can go a little bit further forward. When we talk about even habits and day-to-day routines and lifestyle, because obesity is actually multi-pronged, there are a lot of changes that we can make prior to surgery that help that journey for health and happiness and wellness that lead to also weight loss. And it might be incorporating a little bit more activity or being a bit more conscious about our diet choices and things. If someone's starting a very high BMI or high weight, there are some cases where surgery we see as not safe upfront. And that's where we see some patients may need a bit more help with introduction of GLP-1 medication. So it's not standard for everyone to need that intervention, but if someone's weight, say, is above 180 kilos and they're struggling, if someone's BMI is well over 55 to 60, there may be conversation about introducing GLP-1 medications and assisting them to lose some weight prior to surgery. And that also allows them in many ways to take on some of the changes in lifestyle a bit more easily with the help of a medication. And that thereby brings their weight down a bit more, again, to get all those benefits that I mentioned in that surgical journey. So the place of GLP-1 medications I see prior to surgery can be if someone is at a very high BMI and a high weight and they need to get down to a slightly safer weight for surgery, but that will also make their surgical journey more favourable. Some people may be outside the weight requirements for the hospitals, for example, or the beds and things like that. But also, I mentioned type 2 diabetes. There are patients where their diabetes is not as well controlled prior to surgery as we'd like. And again, we can start to have the conversation about improving the diabetes control, because poorly controlled diabetes can influence healing. And when we talk about an operation, an infection, then we want to obviously have the best outcome. So again, we leave time, and we're talking around at least around a 3 to 4 month window at the minimum to try and allow some of these medications to have their effect so someone can have a better journey long term. The other small group that I should probably mention is patients who are maybe waiting for surgery and they have other reasons why they're waiting. So someone might say, well, I might not be ready for surgery for another 12 months for other reasons, or 18 months. And over that time, I don't want to struggle with my weight, specifically going further and further away from me. There may be something in the interim that I can have to help me manage that time while I'm waiting for surgery. So again, there's a benefit in introducing something like a GLP-1 in that instance. Alternatively, if someone might, and again, we're going to touch on this later on, might be between surgeries where they've had a weight loss procedure and they're considering what to do next. And in the meantime, they just want to look at managing their weight, and potentially another surgery may be on the cards.
Beautiful. Thank you. That was amazing. You just stepped through all the different kind of scenarios. So wonderful. I kind of mentioned this not only because people are listening from Australia, but all over the world. So it really depends on where you are. So we've got all these different factors to consider and places you can use a GLP-1. And just to clarify, you stop that GLP-1 pre-surgery. And what's the timeline that you stop a GLP-1 prior to someone's surgery?
Yeah, so typically we stop it around 2 weeks prior to surgery. And the reason being is that these medications influence the way the stomach empties, or they slow down the way it empties. And so if we continue them up until the surgical date, it can appear with the anaesthetic, where with these surgeries, we need to have an empty stomach, particularly because we don't want to maybe aspirate, get fluid into the lungs. And if someone has delayed gastric emptying, they might have more than fluid in their lungs. But also when we're moving the stomach around, using stapling devices, we don't want the stomach contents within them. So we stop them for that reason.
Okay, beautiful. Yeah. So someone's maybe been on a GLP-1 or not. Anyway, they had their surgery. Let's move on to the next phase of the bariatric journey, that weight loss phase. And that can be different lengths of time for different people. But say you're managing, you're caring for your patient in that weight loss phase, where do you see GLP-1s playing a role there? And do you take into account, I'm guessing you take into account if they've had the pre-surgery, have they responded? I'd love to hear your thoughts about the next phase.
So the idea predominantly when I have a patient who's looking for weight loss surgery is that the goal is to have one intervention like a surgery, and that hopefully will carry them long term. So we don't typically lean on GLP-1s early after surgery for that reason. And a lot of, again, patients may have come from a history of medications and other options. So they actually look at surgery as hopefully an option for them where they don't need these medications. Particularly in the first 12, and I'd say 18 months after surgery, but certainly in the first 12 months after surgery, it's unusual for me to introduce a GLP-1 medication. Often in the first 3 to 6 months of surgery, that's where the most rapid weight loss occurs. And so we already have a mechanism or a tool that's working very well to lose weight, a mechanism of working very well to curb hunger, and a mechanism of working very well to allow people to feel full. So often we don't need another tool to add to that. And obviously GLP-1s do come with other considerations as well, like side effects and cost. And so those are things we generally don't need to look at right there and then unless there's a reason behind it. And so if someone is tracking as they would expect to be in the early recovery, particularly in that first 12-month window, then the idea is to just focus on enhancing all the other things that will increase the power of their tool. So their day-to-day routine, choices, as so forth. And typically, afterwards, we hope that patients will just continue on that journey utilising the tool that they've got. However, some patients may find that maybe they find a period where they plateau or a period where they find that they just haven't lost enough weight overall. And that can sometimes be a time where a conversation like a GLP-1 is considered. Now, plateau's normal after surgery. Weight loss is not a straight line. It's very much of a zigzag, and there's many other ways we measure progress, not just by the scales. However, if someone has sort of hit a plateau and we're talking about maybe a couple of months where things just aren't shifting, certainly more than 3 weeks, then sometimes GLP-1 may be considered. But before we just rush into introducing a medication, we have to look at the whole picture and as to why that plateau has happened or why that person may have not reached the goal that they had hoped to reach. And again, because obesity or weight management is multi-pronged, we have to look at, firstly, are there any anatomical issues related to the surgery itself that are stopping a certain patient losing weight rather than just starting them on a GLP-1? Are there some lifestyle factors that have obviously impacted their journey related to weight loss? Are there some dietary choices or activities that haven't been introduced that may enhance their tool again? Are there some other medical factors, such as a condition that may lead to increased weight gain, like maybe a thyroid dysfunction or a medication? So there's lots of different things that we actually talk about before we just say, let's start a GLP-1 at this point. And typically that conversation, if we had it, the earliest, typically in my experience, would be at 9 months after surgery for an outlier patient. But most commonly, we talk about that well down the track after the 12-month mark.
Beautiful. So I think that touches on a really, I suppose, part of the conversation, but maybe a little bit to the side, is around goals after weight loss surgery. And I think many people feel that bariatric surgery is like this tool to reach a certain weight. And I talk a lot to my clients and online about it's an intervention and results will vary. There's a lot of different factors and things that will impact how much weight you'll lose. And some people lose, it's kind of probably like a bell curve. Is that the right example? But people are going to lose. And I'll just say this because I talk to people all over the world. I'm getting the impression or getting feedback that less surgeons are setting goal or giving goal weights at those initial consultations pre-surgery. They're being less specific with them. What are your thoughts on that?
Great question. And I think you quite rightly said there's a lot of variation. And in my practice, when we talk about goal weights, again, weight is just one element that we measure. And so I very rarely say this is the goal weight. I have an idea very much of what I hope to expect for a patient. So if someone has surgery and they lose 5 kilos, then in my experience, that's an inadequate outcome. So there are some outliers, but in terms of a goal weight, what we talk about in my experience is less about the goal weight and more about the goal of the journey. And so the goal is, what are we doing in that journey to enhance the tool that we have? And that's where the focus is predominantly. And I actually discourage people from weighing themselves all the time. I typically say weigh yourself no more than once a week. And the focus of the rest of the week is actually what are we doing each period of time to grow with the tool that we've got? Because everyone's biologically different. And that's why we see a lot of people struggling with weight and obesity and others don't struggle as much. And in many cases, lifestyle variation may not be that different. And we actually see it in family units where you have different family members exposed to the same environment, but very different outcomes in terms of weight challenges as well. So expectation is the huge part of the conversation prior to surgery. What do I hope for? What do I expect? We know that surgery is very effective, and we know that with a lot of studies, there are some numbers there where we say with gastric sleeve, for example, we aim to lose around about 65% of our excess weight, very conservative. Often most patients will outdo that in my experience. And then with bypass, it may be said close to the range of about 75%, maybe 80%. But again, these are very loose numbers that people should not hold closely, but rather look at their own situation, their own journey and say, well, if I've got a tool that's effective, my focus now is to just enhance that tool. And that's not with living a diet lifestyle, but with a healthy, balanced lifestyle where I continually add to my journey each period of time in terms of my choices and my activity and things like that, with the team obviously supporting you along the way.
Beautiful. There are so many things, and I kind of like really burst into kind of like, woo, when you said about not weighing. I'm going to touch on that because I so agree. I just want to explain excess weight and the percentage of excess weight loss, because some people may be listening to that and thinking, oh, what does that mean? And I mean, sometimes I hear surgeons say, well, look, you may move down a certain number of BMI points. But if we're talking excess weight, what it is, pre-surgery, if we look at the BMI chart, not everyone's favourite, but if we look for your height and look at what your weight would be if you're a BMI of 25, any weight that sits above that weight we call excess. And so we're looking at loss of percentage. So if you lose 100%, you'd go down to a BMI of 25. But yeah, you just mentioned an excess weight loss of 75%, which is really significant. I'm loving also what you're saying about looking past or looking further than the weight. I'm a big fan of my clients not weighing all the time. Weight is a lag measure. The scales in the bathroom are not that accurate, especially when you start exercising more, your muscle can increase. And it's a measure. Let's focus on the things that move the needle. Let's focus on the things that give us the improved pathology results that help your joints ache less. All of those other big picture lifestyle, the non-scale victories. So I'm a big fan of that. And I make a bit of a joke about it. My clients do get to know my sense of humour, but I call them Steve and the scales. And how's your relationship? And often people's relationship with the scales is not that positive. So loosening up that grip on the scales and not focusing just on that, I think that was a wonderful thing to point out. So thank you. Great.
I think you've just touched on a really important point, Jane, just regarding the scales again, because that's been obviously a focus of people for a long time. And when they start to lose weight, particularly fairly rapidly after surgery, a lot of patients do have the need to say, let me keep checking where I'm up to today and tomorrow and the next day and the next day. And invariably, what happens is that there will be times where your weight will actually go up a little bit. That's okay. And then you have plateau, and the anxiety or concerns that can lead to may not be valid. And that's just because we're weighing and we're focusing on just a number rather than the bigger picture. And the bigger picture is that surgery is extremely effective. Obviously, we've got GLP-1s, we've got lots of tools in the bag, and these things do work for many people. But the idea is the focus now shifts to all the factors that can enhance these tools.
Beautiful. I love that. And I talk about it being triggered by the scale. So yes, we expect, people often may think or hope that maintenance is going to be just a flat line. If you graph it, and it's very normal for it to go up and down. As a person that's had weight loss surgery, where do you go if the scale go up? Where do you go? Your head. And that's what I mean. What are your thoughts? And we don't want to be jumping on and being triggered by the scale. So that's the weight loss phase. And at some point after your bariatric surgery, you move into maintenance. And a lot lately, I've been talking a lot about maintenance, and I even did a podcast on why can maintenance be the hardest phase for some people. And I've had clients come to work with me and say, Jane, I don't know what it looks like. I've been all my life in their weight loss career, either putting on weight or losing it. And they don't know how it feels or looks to be maintaining. So maintenance can be where people struggle. The early days can be smooth sailing, which is great. So where do you see GLP-1s and how do you support your patients in the maintenance phase?
So we have a really robust follow-up service. And I think that's one of the real pillars of success we feel with any weight loss journey. I'll touch on that in relation to GLP-1 because what we see is that maintenance phase requires a reliance on certain habits, support, other factors other than the surgery long term. Because the surgery is there, it's a tool, and in many cases it will continue to work, but the reliance on long-term success now falls more on the day-to-day, the week-to-week routines that we put in place, hopefully in that first 12 months, and also in addition to obviously the support of the team around you. And often that will be, it could be a dietitian service, it could be a bariatric group. And maintenance looks like really, I often take people say, back to the first year you had surgery. That's really the bit that I take people back 4, 5, 6 years out of surgery. When they're still talking about maintenance, we talk about, are we still in a similar place in terms of our day-to-day, our routine, our support, all those things to that first year? Because often that first year is the one we invest the most. And that's the one that I often say, let's go back there and just talk a bit about there. Are we still there? And often people are ahead of that year, which is fantastic. And some people will say, well, I'm not where I was before. Then we talk about getting there. And some people say, well, I am there. And that's why I feel like I'm really enjoying this journey. We have fairly regular follow-ups in terms of nutrition support and, again, blood tests being part of that process. And it's really just that conversation, that link. And we've actually seen that studies show that patients who have ongoing follow-up have better success. And we're talking about 5 years out of surgery, 3 to 5 years out. If you have ongoing follow-up with your bariatric team, you're more likely they lose a bit in the order of about 5-10% additional excess weight compared to patients who don't. I'm not saying that there's some patients who obviously can continue that journey alone, but we find that support's necessary. Regarding GLP-1 medications, being supported by a service means that we are able to intervene early if we find that we are no longer adhering to maybe the maintenance journey that we were on before. So we're finding that slowly we are deviating or falling away from the weight goals or the progress goals that we had. And it can be easier for us to sometimes recognise that, where the patient or someone who's had surgery may not be aware what's happening in the background, and then they come when they're a lot further away and they say, and now I need some support or help. And so when we come back to that conversation about plateauing or weight regain, more so weight regain, because again, we're in the maintenance phase, that's when we start to say, well, now we look at all those factors. Why have we regained weight first? And part of that conversation may be a GLP-1 as well. So if we've excluded and worked on some of the day-to-day lifestyle habits and factors, the dietary factors, it could be a psychological factor. Again, we know that half the battle is in the head, and life happens and things come in the way. Is there an outstanding medical condition? Have we talked, are there medications in the picture? All these factors. And then if we've actually worked to look at all that, then we say, well, now we want to get this under control. We want to see if we can start to get back on that journey close to where we were. And now a GLP-1 medication might be a good option for you. That again, when we talk about the context of what else is there is surgery as well, but this is a safer approach in many ways, but it does have risks, and we can touch on those as well. But it is a way to start to get back on track effectively.
Beautiful, beautiful. I'll come back to risks. I think that would be a great conversation. I loved what you said about that long-term support. It's lovely that you offer that. Not everyone gets it. And I think we need to do better at selling the benefits of having long-term support, and that it's really normal to need it. Because so often people say, I'm reaching out, but I should be able to do this on my own. Or they have gained some weight and then they feel some shame or embarrassment to go back to their centre. So I think that long-term conversation about managing the disease of obesity and knowing that you don't have to do it on your own, and knowing that, I call it building your team. So you've got your surgeon, your dietitian, psychologist, exercise person, primary care provider. The example is when people are diagnosed with the disease of diabetes, they get lots of education, long-term support, different people they connect with for the rest of their life. It's the same thing. So thank you for sharing that research, because the evidence is there. I think people feel that they should have, or they have the bariatric surgery, many people, and think they should be able to do it on their own after off they go. And there's that shame of reaching back out. I love what you said about early intervention. Much better to gain 5 kilos and let's do something about it than gain 20 kilos, for example, and then saying, oh, okay, I need some support. We want to nip it in, that we want to know that it's really normal and expected to regain some weight after surgery. It happens, we just want to manage it. So those points are really wonderful. In every medication, there are risks or there are side effects. I'd love you to share a little bit more about that. I mean, it's a class, it's not just one medication, it's a class, but yeah, that'd be great.
Yeah, so just to touch on that support journey as well, I think that does apply to GLP medications as well. Because again, some people may be seeing some of these medications just a medication on their own, but no different to surgery, and they work in the context often of a team. We know with weight loss, there's challenges being that obviously there's lots of aspects to it, but again, having a dietitian involved, even with a GLP-1, looking at activity, even with a GLP-1, all the things that we look at with surgery, because they enhance the tool of surgery, also are very important to look at with the tool of GLP-1s. When you have a group, when we talk about risks and considerations, when someone's had weight loss surgery, there are some specific considerations in addition to the general considerations where we start a GLP-1 medication. So when we talk about the general population or the general considerations, so there's certain groups that we wouldn't prescribe a GLP-1, so not everyone's eligible. Say if someone has a specific rare type of thyroid cancer, it's called thyroid carcinoma, or a family history of that. So this is what you work through your support team and your doctor about, am I suitable first of all? So people with that type of history, people with a history of pancreatitis may or may not be considered, because that can be exacerbated. People who are looking at along the lines of pregnancy, so looking to conceive early on or have it during pregnancy or even early afterwards, breastfeeding. So there's lots of other factors that come into whether someone's actually suitable for these medications, but also from the gut. We know these affect the gut, and if someone's underlying gut issues, particularly what's called gastroparesis or slow gastric emptying, again, those may be people who may not be considered. So some of the side effects are things like nausea. They can affect your gut with changes in your bowels, constipation, diarrhea. Those are some of the things that people may experience early on, and sometimes we can work through a lot of those factors with support, management, medications, what different ways of eating, times to inject, a lot of variation, changing the dose, and so forth. But in terms of our group of patients who have weight loss surgery, if you think about it, someone's already got a smaller stomach, and someone may also be more prone to nausea. So we might have to monitor that person a bit more closely because their effective nausea might be greater than someone who's never had surgery, for example. From a nutritional point of view, once again, if someone's eating smaller meals, even on a GLP-1 medication, there is a chance you can get deficiencies that you may not know about because the blood test or the check was never done before the medication, and you may not be on a supplement afterwards. But if someone's already had weight loss surgery, that may be more profound. Particularly if someone's further from surgery, they may no longer be on their multivitamin and they're now on a GLP-1. In addition to that, their risk of nutritional deficiency, even with a gastric sleeve, may be more pronounced. And again, having a team rather than just a medication that they take without any particular support or monitoring may mean that things can get missed along the way. So those are some of the considerations that I look at in that time, particularly related to risks and considerations for weight loss surgery. The other thing I probably should touch on is when we talk about deficiencies from a dietitian viewpoint, I know that this is something that you look at very closely. We talk not only about the micronutrients, iron, vitamin B12 and vitamin D, but also looking at things like protein, the building block. People often forget protein being one of the main things that we need to focus on, even on a GLP-1, as part of that journey for success.
And there's some great research coming out looking at people on a GLP-1, even if they haven't had bariatric surgery, having suboptimal protein intake and also calcium intake, so bone density. So beautiful. People are going to become much more aware of because some people are not having this conversation with you. They are going to their primary care provider, getting the medication, and yeah, things are coming out around people on the medications. Now, I want to ask you about gastric emptying. This is in a Roux-en-Y, because when people have a Roux-en-Y bypass and they have a pouch and they lose their pyloric sphincter, where do we know much about the mechanics? Like, I'm a visual person. I'm imagining the sleeve. If you Google what a sleeve looks like, we've got a smaller tummy, but we've kept that pyloric sphincter. After a Roux-en-Y, we've lost it. Is that part of impact of the efficacy of the medications?
I don't know if there's actually been studies about the effect of gastric emptying on Roux-en-Y gastric bypass specifically. We know globally will have some effect on gastric emptying, but we do know, as you quite rightly mentioned, the control valve for emptying the pylorus, we don't use with it if someone's got certain specific types of bypasses. The Roux-en-Y is one of them. The single anastomosis or the omega loop gastric bypass is another variety where there's almost free flow in some ways. However, there is some dynamics within the stomach that still are affected by the GLP-1 medications that influence gastric emptying. So I still believe there is an effect in those patients. It may be a lesser effect, but again, as we know, GLP-1 has lots of ways in which it works, and that's one of them. But obviously that central appetite suppression being another significant factor. And I don't know that we've actually separated how much influence one of the factors, like how much appetite suppression do we get and how much delayed gastric emptying effect do we get for the medication. So I think it's just a global observation based on the study.
Beautiful. Yeah. From what I've read and listened to, so much more research is happening in this area. And yeah, I think we'll get more answers in time. But no, thank you for that. It just kind of came up for any of the science people listening and maybe a bit more analytical about it. So thank you so much. I found that really, really interesting. I know listeners as well. Please add anything you would like to add, as well as where can people connect with you and find you? I'd love you to share that.
Right. Well, I guess just to add to some of the considerations for GLP-1 medications is muscle loss. And I think this is something that, again, may not be front and center for a lot of people who have started these medications, but as part of that weight loss, we don't just lose fat. There's different types of weight we all carry, and muscle being part of weight is actually lost in the journey for many patients, not only who have weight loss surgery, but also who have GLP-1 medications. And that loss of muscle is early on. And so once again, that conversation with a specialist team where we can support you, can have a conversation about how we can try and maintain that muscle in your journey. And we talk about the ranges, a significant portion. We talk about 20, sometimes 30% in terms of part of that weight being just muscle. So that's just something again, just to leave people to consider, if you are on a GLP-1 medication, resistance training, muscle maintenance, not only will enhance your weight loss and improve your general health and your energy levels, but also as we get older, it can be harder to regain or maintain that muscle, especially if we're losing it quickly on a medication.
So teaming adequate protein with resistance activity.
And being aware of that early on. My encouragement is actually when patients are looking to start a GLP-1 medication, if they're flagged it early, we say, let's start to set ourselves up for GLP-1 success. And part of that is saying, well, how can we start to put some of these things in process so when we start the medication, we're already on the front foot in many ways. So, but absolutely, protein and resistance training is really important. And again, it just depends on what you're able to do. It doesn't mean the gym membership straight away. There are lots of different types of options available, and they can still play a big role.
Beautiful, beautiful. So thank you so much for that. I'm totally in agreement there. Yeah, where can people find you? Touch base.
Absolutely. So from a physical point of view, we are based in Joondalup and Canning Vale, so both north and south of the river in Perth. But we obviously harness a lot of patients who are not even in Perth, but interstate. We have patients who have reached out to us, certainly in regional areas. And so we are available for telehealth consultations as well. So video telehealth consultations. As in terms, I operate across, again, north and south here in Perth in private practice. We have very active social media as well. So we are branching out. And so you can reach us on at bmi.com.au. So our email obviously will be in the show notes, but hello@bmiclinic.com.au is where you can actually reach out. You don't have to come in for surgery. No, it's just an inquiry. You want to learn more about GLP-1s, which we have a lot of patients who just come in for management of GLP-1. A lot of patients who just come in for weight loss advice, and maybe surgery or non-surgical is an option. And again, we have the whole team providing a lot of other services related to that.
Beautiful. And we'll definitely put your contact details, including your Instagram. And I was smiling before because you've got very shiny shoes, I don't know, in your with some cool music in Instagram. So we'll put all of those places that people can reach out and contact you. So thank you so much for your time today. I know you're really busy, but I really appreciate your time. And thank you so much.
Absolutely, pleasure, and thank you. And I hope that was obviously helpful for a lot of people out there on GLP-1s or considering them, or obviously just how they work with surgery. Because again, I guess the overall comment that I'll make is that we don't just have one or the other, GLP-1s or surgery. We actually often have them working together in many cases. They can work together for a lot of people. And that's obviously the conversation we have when people come through our doors. Beautiful. Well, thank you so much for your time. Thank you everyone for listening to this podcast. And I really look forward to being back in your ears very soon. Bye for now.